Good afternoon, and thank you for joining us for Healthline 3. I'm Carly Flynn Morgan. Today we're joined by Dr. Paul Bracey with Urgent Care of Louisiana. He'll be answering your questions about skin infections, abscesses, and MRSA for the next half an hour. And we want to encourage you to ask the questions that are on your mind about this topic. If you're online, just fill out the information screen on ktbs.com. You can find that at ktbs.com. To the right of the page and down a little bit, it's an orange box. You can submit your questions there or give us a phone call. The number is 318-219-4569. We'll be taking your questions until 12:30 for the next half an hour. Dr. Bracey, thank you so much for being here with us.
Thanks, Carly.
And it's a topic that can be a little embarrassing. Skin infections aren't the most, attractive of things, and nobody wants to have to deal with them. Tell us a little bit about the different type of skin infections that are out there.
Well, today we're mostly probably going to be covering things like abscesses, cellulitis, which is a superficial skin infection, and kind of the range between those. There are several others. If you could probably spend an entire day lecturing and learning about skin infections, various types. But those are the two big things that we kind of talk about today, and then specifically talk about MRSA as a common culprit nowadays.
Okay, and right off the bat here, we actually do have a caller. Karen is calling in, so let's hear from her. Karen, what's your concern?
Well, I have this place on my leg, and I'm like a 2-year-old. I think I have to scratch it, so I scratched it. And the other day I noticed that I had a place coming up by my lip, by my lips, on my little area right there by your lips. And I don't know what it is. I don't know what to do about it. I'm trying to see, what I should do about it.
So you said that there's a scratch on your lip?
It's not a scratch. It's like a little area. It's like I don't know if you call it, it's not really a sore. It's just a place that came up, and I've been sitting in antiseptic ointment on it, and it's not helping it, and I just don't know what else to do.
Do you need a description of what it looks like, or what do you think?
Well, thanks for calling, Karen. Appreciate it.
You're welcome.
Rashes can be one of the most difficult things to make a diagnosis on without actually looking at it. There's so many different types of rashes and so many different ways to characterize those rashes that really laying eyes on it and seeing the particular rash that you're talking about is the best way to make a diagnosis. And you said you also happen to have one on your leg as well, or is that one resolved?
Yes, sir. It's not. They're not really rashes. They're on my leg. It's like a. I don't know. I guess you can call it a sore, but I've been scratching it, and anyway, that's on my leg. I've been whatever kind of word that is. I'm on it, and that's helping on my leg to a degree, but I've been sitting right there by my mouth. They're right there by my mouth, and it's not even helping now. I just didn't know what else to do.
If you've kind of exhausted all of the home remedies, the over-the-counter topical medications, I would suggest getting it looked at. It may not be infectious. It may not be something that an antibacterial topical ointment is going to really help with. It could be inflammatory. It could be autoimmune. It could be any number of things. So it's probably best to get it looked at. And that can be done either through your primary care physician, through an urgent care clinic setting, or through a dermatologist if you have one already.
Okay.
But any of those venues would be good places to have that evaluated.
So you do think the next step, if it doesn't go away, Dr. Bracey, is to get it checked out by a doctor?
Right, because there are a number of things that it could be, and it's best not to ignore these, especially if it's persistent and it's not resolving with your usual over-the-counter kind of treatment plans that you tend to use at home.
Okay, Karen, thank you so much for calling. We hope you get that resolved.
Yes, ma'am. Thank you.
Sure, thank you so
Thank you.
much. Tell us a little bit, you were mentioning the different types of skin infections, MRSA, cellulitis, I think you called it. How do you know the difference between them?
Well, cellulitis is a superficial skin infection that spreads kind of along the superficial planes of just the skin. It doesn't extend any deeper. It is associated with redness and warmth, sometimes tenderness of varying degrees, and can also be associated with systemic symptoms like fever, chills, fatigue, malaise. So that's kind of a good description of cellulitis. Now, cellulitis does not have to be caused by MRSA. But most cases of cellulitis are either staph or sometimes strep. So it doesn't have to be the MRSA staph, though. MRSA is kind of has become an emerging illness in the United States over about the past 10 to 15 years. I mean, it existed before in hospitals, and because those are places where high concentrations of antibiotics are used, and now over the past 10 to 15 years has crept out into the community, and now it's not just one set type of MRSA. There are different types of MRSA. So there's actually a community-acquired version of MRSA that is genetically different than the hospital-acquired version. So it's kind of a different subset of MRSA. So when we talk about MRSA, it's actually not just one lump group of bugs. It's a couple different kinds. But MRSA has kind of become the predominant strain that you see in skin and soft tissue infections, so much so that all of the recommendations have been rewritten to accommodate for MRSA. In many areas of the country, it's the #1 pathogen to cause these. So, but cellulitis is one, abscesses are another one that you'll frequently see with MRSA, and MRSA tends to cause deeper abscesses than traditional penicillin or methicillin sensitive staph. So those are kind of two different culprits. You can also have things like impetigo. Impetigo is a very surface type streptococcal skin infection that is associated mostly with children. Adults can get it as well, but tends to form on sores that are already present, like mosquito bites.
Well, we do have another caller at this point in time. Jane has a question for Dr. Bracey. Jane, are you there?
Yes.
Go ahead and ask your question.
Okay, well, in about October, I noticed in the pubic area, kind of on the top, like a dark purple bump or thing, and I went to my gynecologist, and they told me it was staph. So I took, I couldn't take the doxycycline. It made me very ill, so they put me on Bactrim nasal.
Mm-hmm.
Took that. Then it came back as soon as I got through taking that. It came back. Got through using it. So then I decided, well, I'm just going to make myself take the doxycycline. So I took it, and that seemed to work. But the other day, I have been putting. I got some Methicillin-resistant ointment.
Right,
I
that
know
was
I'm
hard
not
to
saying
say.
that right. I'm saying it real wrong, right?
No, you were very good. That was very good.
Okay. I've been, as a precaution, putting that on the two places I had, and they're just were faintly discolored. But the other day, I thought it was a bruise, and then I realized I put some of that on there, and the next day I realized it was probably another thing. So I put the ointment on there, and it kind of went away. But what I'm wondering is it coming back?
Well, and that's always a concern. And thanks for the call.
And what should I do? Because I got on the internet. I'm sorry, I'm interrupted, I know, but I'm 71 and I am a diabetic. But I got on the internet, and that's the worst thing you can do because it's so scary. And it says it does come back.
You will frequently see people who have recurrent infections of staph. And part of that is because staph likes to live in certain areas of our bodies. And those areas tend to be the nose, what we term the axilla or the armpits, the groin, and around the anus. And it's kind of odd to say on the air and on TV.
I know.
But I mean, that's just kind of where the bacteria likes to live, and that's one of the reasons that the Bactrim or mupirocin ointment is used intranasally, because many people will carry the bacteria without having an active infection, and one of the spaces in the body to carry it is inside the nose. And there's been some data that's come out relatively recently that shows it probably lives a little deeper in the nasal recesses than we formerly believed. But so that's one reason why that eradication therapy that you're describing is not always successful. But we try to use that Bactroban, that nasal antibiotic, twice a day for a minimum of 5 days.
I did that. Yeah, and you're supposed to rub it, like massage it 20 times.
Exactly.
And I did that faithfully.
And you can do all the right things. And I frequently tell my patients, you can do all the right things. It has nothing to do with hygiene. You just came in contact with a bacteria that's posing you a little bit of a problem. So another option is to use a soap called Hibiclens, which is originally was a surgical scrub to bathe and shower with. Hibiclens, it's Hibiclens, and it is a surgical scrub. The way to use it is to once a day. You don't have to get over the top with it, but once a day for about a week to 10 days, in the shower, wet your body down, point the shower head away from you, wash with the Hibiclens and let it stand on your skin for about 5 minutes, and then you rinse it off, and it will actually continue its killing action even after you rinse it off. So, but you pay special attention to the areas of the body that we mentioned, and that is part of the attempt to eradicate the carrier state for MRSA. And
is it internal? I mean, is it all? If I have it on my skin, is it also internal?
It's not seeding through the bloodstream. It's seeding topically. So you'll carry it in your nose. So technically it's internal because it's in the nose, or what we call the nasopharynx, and then in these other areas of the body. But it infects topically. You can have MRSA that gets aggressive if during an active infection that seeds the bloodstream. That's something called septicemia, but that's is not usually how it
really
spreads.
Scared me. It really did. But my doctors at that time said yours is not that bad.
Right. And it sounds like they're correct. But in a 71-year-old, and especially a diabetic, it is something that we need to that you want to stay on top of and make sure you're eradicating each time the infection recurs.
Jane, we appreciate you so much for calling.
Do you think if it comes back and I put that ointment on there, that's a good enough treatment for it?
Many times it can be, especially if you're using warm compresses as well. But again, as a diabetic, you want to pay real close attention to how quickly it tries to spread.
Good advice there, Dr. Bracey. Jane, thanks so much for calling.
Thank you so much, and I'm sorry I kept you so long, but I really do appreciate it.
That's okay. We hope you get that taken care of.
Thank you.
You're welcome. We actually do have another caller right now, and her name is Dolores. Hey, Dolores, thanks so much for calling.
Hey, I'm still here.
Okay, good. Go ahead and explain your concern to Dr. Bracey.
All right, let me give you some information. I'm not diabetic. I'm 81 years old, and I weigh 143 pounds, and I have good blood pressure, but I have ringworm, for goodness sake.
Yeah.
And so I have been to the dermatologist and have gotten a prescription, but is there anything I can do? He didn't tell me, does it like air or it doesn't like air, or what's your suggestion other than putting this cream on it? Is there something else I could do?
Well, thanks for calling, Dolores. I appreciate it. We, first of all, if it's not too embarrassing to ask, where is your ringworm?
My a ringworm is on my ankle, so to speak, on both sides of my ankle bone.
Okay. If it's limited to that small area, then topical antifungals would be the way to go.
And maybe it just takes a long time, huh?
It does. And unfortunately, ringworm is one of those skin infections that tends to recur because most times people will undertreat it when they're using a topical ointment or cream. So you want to use that topical cream until the rash disappears, And I usually tell my patients to be on the safe side, to continue to use it topically in that same spot for another 2 to 3 weeks, because the rash will disappear before the fungus is completely killed. So you'll want to continue to use that for about 2 or 3 weeks afterwards.
There's no quick fix for this.
No, unfortunately, there's not. There's not.
And I'm too old to have the darn thing.
Well, I wouldn't go blaming the grandkids or anybody yet.
I don't have a cat,
Well,
I don't know.
These fungi are all over the place. We come in contact with them all the time, and nobody really knows why. At some point in our life, we don't really kill it off effectively, and it kind of gets a latch on.
Now,
to
it's easy to pass on, isn't it?
It is probably not one of the easiest infections to pass on, but it is contagious.
I need to go back to an exercise program where I just go and walk in the swimming pool. Would I give everybody in Shreveport ringworm that got in there?
You shouldn't, not if the swimming pool is appropriately chlorinated.
Yeah, well, it's in Willis Knighton Health Center, so
yeah. So
I mean,
if they're taking their precautions with their swimming pool and keeping it clean and keeping it chlorinated, that you should be okay as far as passing that on.
Okay, well, that helps me.
No,
very good.
You will have to pay attention in the showers, because that could be where you caught it, though, because it frequently loves to live in those warm, moist tiles, and that is a common way for people to encounter these types of fungi and get infected that way.
Well, I could go home without a shower, but I need to wash that off too, don't I? Well, anyway, I will just be real careful, and maybe there won't. The other day when I was up there weren't but about 2 old people in there, so that you guess that would be not as bad as a bunch of children being in there, of course.
At least you're limiting the exposure a little bit that way. Yeah.
I don't know I understand what you've told me, that it's not easy to get rid of, that I have to be very, very careful and very attentive to doctoring it. Is that correct?
Inconsistent. That's unfortunately, yeah. There's not a fast fix. There are some oral medications that can be used to treat fungal infections, but those have to be taken for a pretty extended period of time and can be really rough on the liver. So you want to, if you can use if it's a small area like you suggest, you want to use those topicals and really give them as much effort as you can before deciding to go to the orals.
I can spell it for you. It's CICIOPIROX.
Yeah, that's a common antifungal topical medication.
Okay, and that's from Dr. Clemens. Yeah. Okay.
Well, I hear really good things about it.
I'll see how this goes, and I'll talk to him and see if he has any ideas. But you've helped me by saying it's hard to get rid of. So I'm like some of these people that want instant, you know.
Well, unfortunately, this is one of those cases where I can't give you that.
It's not going to happen, so just relax and keep treating it, huh?
Dolores, thank you so much for calling.
Well, thank you for your time. I appreciate it.
You're welcome.
You know, we've helped you, but we've helped other people. I'm sure plenty of people are dealing with ringworm and have questions about that and wondering about that. Now, these ladies have taken some action and called about some issues that they're seeing. What are some signs that you should quit ignoring a skin infection and that you need to take the next step and call your doctor or visit your doctor?
Well, a really important sign is pain. So if you're experiencing pain with the skin infection, you definitely want to get that checked out. Especially if there's pain that what we term as pain out of proportion to what we see on exam. So if it looks like it's a ditzel but it hurts like crazy, you need to get it checked out, because that could mean a deeper infection's present, and it could be more aggressive than it appears just on the surface. So most of these infections are easily dealt with, but every now and then you'll find one that presents like that necrotizing fasciitis that we discussed in the news segment, where it's extremely painful, but when you look at the skin, it looks relatively okay early on, and it can be easily deceiving. So pain, definitely. If you start having any systemic symptoms, if you start having a fever, if you're having chills, the rigors, the shaking chills, if you're feeling just very run down and much more so than usual, very fatigued, those are other markers of systemic illness and that it could be a little more invasive than what it appears.
I wouldn't have guessed that a skin infection could bring a fever or chills. So that is something that may be associated with some sort of skin infection you have on your body.
Yeah, you can see that. You don't have to see that, but you can see that with cellulitis. And the more aggressive the bug, the bacteria, and the more rapid onset the rash, that tends to tell you that there's a more aggressive course of illness. So the one thing that's associated with worse outcomes is rapidity of onset of the rash when we talk about things like cellulitis. So those are things to look out for. Now, and then aside from that, the usual things that a lot of people kind of know, just the general public tend to know, is the redness associated with the rash, and then the red streaks that everybody seems to kind of be familiar with. The streaks kind of running up the limb, the extremity, kind of towards the trunk, as a possible sign for what we call lymphangitis, but spreading of that infection along the lymphatic channels. It's actually not. A lot of people believe that under the misunderstanding that's it spreading through the veins, although that can happen, but much more commonly it spreads through the lymphatic channels. So the red streakings.
Gotcha. We have another caller at this point in time. It's Kenny. Kenny, thank you so much for calling. Can you hear me?
Yes, ma'am, I can.
Okay, go ahead and
Hi,
ask
Kenny.
Dr. Bracey your question.
Okay, yeah. I want to ask you that I've been getting this cellulitis. I guess that's how you pronounce it. But like this time it was on my finger and it had to get lanced and drained, and then they put a little piece of gauze in there to keep it drained. But I got this like about 4 or 5 years ago on my leg, and then twice, and then 3 times. Does that come from like mildew in the house? Can it come from that too?
No, it typically is not going to come from mildew. Cellulitis is I'm turning my volume up a little bit. Cellulitis is a bacterial infection, whereas mildew and things like that are fungal infections. Now, there are certain fungal infections that can increase your risk of developing cellulitis, things like athlete's foot. People who suffer from athlete's foot can develop cellulitis in the foot and leg. And so...
Well, can I cut you off?
No, go ahead. Go ahead.
It started out like a little pimple, like an ant bite. And so what I did is I popped it. I shouldn't have done that. But then it increased, and it got infected and swelled up. Yeah. And then it had to get lanced.
Yeah, it sounds like like you developed an abscess. And this was the one on your finger?
Yes.
Yeah. So there are a couple different types of infections on the finger, depending on their location. But many times sometimes they'll need to be lanced, and then. Yeah. Well, I mean, it was
cellulitis. But I mean, what am I around that? I pain a lot, and I maybe thought that was contagious.
Well, when you start getting them on the finger, a lot of times that has to do with nail hygiene. So if you trim your nails too close, or if you bite your fingernails.
I mean, it was up by the hand, by the end of the finger towards the hand. It wasn't from the fingernail.
Yeah, and I'll frequently see that in people who are use their hands for work a lot. So if you get scratches, if you get, if you're sanding or you're scraping, doing the prep work for painting, then it wouldn't be unusual for you to have injuries to the knuckle area, the fingers, and any scratch, any break in the skin can serve as a portal for that bacteria to get in there and set up an infection and possibly cause an abscess, as well as cellulitis.
Keep your hands washed. Right?
Keep your hands washed, yeah. And if you can, if you can wear some sort of gloves or something when you're doing that, that might help prevent injury to the skin and prevent the way the bacteria gets in there.
All right.
And if they get dried and cracked, they can do the same thing.
Yes. Well, you answered all my questions, so I hope you have a good day.
Well, thank you. Thank you. You too.
Kenny, thank you so much for calling. Good advice there. Keep your hands washed. If you work with your hands, wear gloves if you can. Is that something that will usually help?
Yeah, if you can kind of limit a breakdown in the skin. The bacteria get in typically through wounds. It may not even be a wound that you're aware of. It may not be one that's easily visible on the skin, but we're talking about microscopic organisms, so they don't need much of a break to be able to access that. Our bodies are remarkable things, and they do tend to keep a lot of these infections at bay, but it's easy to overlook hand washing and let that bacteria kind of get in.
We're talking about hands here. Is that the part of the body that is most at risk for infection, or is there one that you particularly see a lot of action?
It just depends, I guess, from patient to patient. We'll see a lot of cellulitis involving the upper extremities, probably not so much the hands as I would say the forearm. Hand infections can spread quickly. They can become dangerous pretty quickly, especially on the palmar aspect of the hand. But we'll see a lot of times in lower extremities, especially people who are diabetic, and people who have what's termed lymphedema or any sort of edema for any reason, the swelling in the extremity that compromises blood flow, and then people who have problems with their immune status, like diabetics. So those are the kind of groups of people and the locations. We'll frequently see leg cellulitis below the knee, especially in people who have problems with swelling. People who have problems with swelling can form ulcers because of the swelling, and then those can get infected as well. But you don't have to have the ulcers to even get the infection. You'll see them kind of occur almost spontaneously.
If people don't treat their infections, if they don't want to go to the doctor or don't know that they should, what is the worst thing that could happen? What's the worst case scenario?
Well, the most dramatic, worst case scenario would be a fatality.
That can happen from something as simple as a skin infection.
Well, it can, not really from simple skin infections. Usually it's because somebody's let it go, or you've gotten a particularly bad bacteria. But they can be fatal. It's cellulitis if it continues to spread. Like we mentioned, the systemic symptoms, that's because the bacteria is becoming more aggressive, is starting to seed the bloodstream, and then can lead to sepsis and septic shock. For other organisms that cause like necrotizing fasciitis, amputation. So there are some serious complications if these infections are left unchecked.
We have another caller right now, Kira. Thank you so much for calling. You can address your question to Dr. Bracey.
Hi, Kira.
Yes. I've got these little white spots that have been popping up all over my skin for the past couple of years, and I was told it was a form of skin cancer. Is there any treatments or anything you could possibly give me?
Now that's going to be a really tough one without reviewing your chart or seeing those things themselves. And do they spontaneously go away, or are you having to go have them either frozen or removed surgically?
Okay. I was told it was like a form of me losing my skin pigmentation.
Oh, okay. I thought you said skin cancer. Yeah, we can, and it doesn't matter how much or how dark or how fair-skinned you are. That's something called vitiligo, and it tends to be more noticeable in people who are dark-skinned, but people who are fair-skinned can have that too, and it's a loss of the skin pigment in the skin, in the lower layers of the skin. Unfortunately, as far as I'm aware, vitiligo is a permanent thing. There's no active treatment for it.
Oh, okay.
It's a loss of the pigment itself, and so you'll see that sometimes in people who are out in the sun a lot, and you lose the ability to form that pigment anymore, and so you'll have patches of skin that are wider than the surrounding skin because of that loss of pigment. But unfortunately, there's no real treatment for that, especially over the counter or anything. I would avoid sunlight as much as possible.
Kira, we thank you so much for calling. We hope that answered all your questions. We're running out of time. We only have about 30 seconds left here, but Dr. Paul Bracey, we thank you so much. Really important information for people. Something a little embarrassing, but people deal with this day in
right.
and day out, and we need to know what to watch out for and what to do when we see certain symptoms. Dr. Bracey from Urgent Care of Louisiana, thank you so much for being here with us today.
Thank you.
We'll see you next time, everybody.